or reserved bit. So say British Constitution. British Constitution.
British Constitution.
So he's scanning for words. So the next one, please allow them to jump. So the next one is going to be tone, hypotonia. So how to check for hypotonia? How to check for hypotonia, guys? How do you usually check for hypotonia? So first we try to. So if it's hypotonia, we try to palpate. The muscle seems to be less rigid, less tight. It's flabby to touch. Okay. So the next thing what we do is tap test. Tap test. So we try to extend them and try to, let's say, we flash it on this side, hypotonia. If we're going to tap in there, this ring will be having, and this one more stick. So a tap test we can do. A tap test we can do. Or we ask him to hold an object and ask him to involve it, or we might start to talk with him. So he'll be dropping it. Or he'll be dropping it. So we can do a tap test. We can do a palpation through that, or we can ask him to distract. Well, he's trying to do a movement. Test for hypotonia. So the next thing, what you say was, the next one, cerebellar drift. So cerebellar drift, so we got two kind of drift. One is pronator drift. Pronator drift, right, goes downwards. This is a sign of upper motor neuron lesion. Upper motor neuron lesion. Pronator drift. Pronator drift. Cerebellar drift, extended, palms are facing upwards, eyes closed. What happens? It goes down and outwards, or it goes upwards and outwards. Cerebellar drift. Cerebellar drift. Let's close it over. You tried it? We have tried it. Right. And cerebellar patient. Cerebellar drift. Cerebellar drift. So the next one, what we call as asthenia. Asthenia means generalized sense of weakness. It's not muscular weakness. It's not muscular weakness. A generalized sense of weakness. What we feel when we come to the class, right? After some time we get weak, right? So the next thing is going to be your rebound phenomenon. Rebound phenomenon. For rebound phenomenon, you have to keep your hand and try to extend your arm, forearm. You try to resist it. Okay. So what we try to do in a normal individual, when we leave it, there is inhibition, there is control. But in a person with cerebellar disorder, there is no inhibition, no control. So he will slap himself. So that's why we keep the hand like this. The next one, what we saw was movement decomposition or dyssynergia. Dyssynergia is called as movement decomposition. So what we try to do is, we try to ask him to do a movement. In a normal, try to take it out, sir. In a normal movement, the entire movement seems to be fluid. Fluid means in a sequence, in a whole sequence, is able to do that. But in a person with a cerebellar disorder, so reflection, extension, reflection, then. So each movement is broken down into individual components. Yeah. So we call it as movement decomposition or dyssynergy. So the next one is going to be your pendular reflexes. Anyone has got a knee hammer? 5 months.
In my car.
So a pendular reflex, what happens here is, so what happens? You try to do the knee test. So what happens? Wow. Hyper excited. So what happens in a normal person? It extends and comes down, right? In a pendular reflex, what happens? It extends and moves for 3 or 4 times, then drops down. It's because of hypotonia. It's because of hypotonia. Hypo, because reduced tone. So it acts like a pendulum.
But embrace?
No, because the tone is reduced, so the link becomes loosened, slack. So the reflex behaves in a pendular-like way. It moves for a few seconds, then stops. then drops on its own weight. It moves for a few seconds and drops on its own weight. That's your pendular reflex. So pendular reflex is a sign of cerebellar dysfunction. So these are some of the things. So if you want to make it further, if you want to know, before you go further, I think it will be useful for us to understand different types of ataxia. Generally, different types of ataxia. Can you please turn around? So before we go further, I think sit. It's very useful to always understand the structure that we are trying to look into. Cerebellum. Cerebellum is forebrain, midbrain, or hindbrain. Which structure la? Cerebellum is a forebrain, midbrain, or hindbrain structure. So, no. Hello? This, for example, the brain has been from the top. Top is forebrain. Okay? I think this will be more easier. So, forebrain, midbrain, hindbrain. Forebrain, your cerebrum and other things. Midbrain, your pons, medulla, midbrain. Then your hindbrain contains your cerebellum and your medullary area. Okay, fine. So the cerebellum belongs to the hindbrain structure. The cerebellum is called as little brain. Why? Because it contains only 10% of the volume. Let's say the brain is 100%. Cerebellum covers 10% of it. The volume is 10%. But more than 50% of the neurons are present in the cerebellum. If there are 100 neurons in the brain, 50 neurons are present in the cerebellum. So it has got a lot of neurons. And how many lobes it has got? How many lobes? 3 lobe structure. Anterior lobe, posterior lobe, and flock lobe, nodular lobe. How many hemisphere? 2 hemisphere connected by a midline structure, what we call as, starts with V. Starts with V. Vermis. Connected by vermis. You got it right, guys? So connected by vermis. That we are connected. So 2 hemispheres connected by vermis, 3 lobe structure. So now we have to understand it's been divided into 3 areas. 3 areas. Forget the lobe, forget the hemisphere. Now we are talking about the divisions as such. Divisions as such. So the divisions of the cerebellum will be cerebellum. Cerebellum. The next one will be vestibulocerebellum. The third one is going to be spinocerebellum. So we understand it's connected with each structure. So cerebellum is connected with cerebrum. So the cerebellum will be involved with, because it's connected with cerebrum. So it's going to involve with what? Cerebellum, cerebellum. So this part of cerebellum is going to get involved with what kind of function? Cerebrum is always dealing with planning, execution, learning, cognition, memory. So this one is going to do with motor planning. Motor planning, all those things is going to be your cerebellum. Then vestibulocerebellum. So it has to deal with vestibulo. ENT. Ears are dealing with what? What function?
Balance.
Balance. So vestibulo, then also eye movements. Then also with eye movements. Then you got your spinocerebellum. So spinocerebellum is dealing with muscle tone. That you have to remember. Then if you're coming across in your clinical practice, I can touch you right. In your clinical practice, if you're coming across ataxia, there could be different types. The most common, that type that you're trying to see today is cerebellar ataxia, which is mostly with motor problems. But there could be other ataxia. For example, we can come across something what we call as frontal ataxia. So frontal lobe function is Very good. So there will be a problem with cognition along with motor problems. The person will have motor problems, but he or she will also have problem with cognition, memory, learning, all those things. So how to differentiate frontal lobe ataxia from a cerebellar ataxia? If you're going to observe the patient, can you move a little bit?
Whoa.
Not like a Michael Jackson.
Yeah.
A little bit
You
like
move.
that. Move. So if you know, so frontal ataxia, when you observe someone with frontal ataxia, they walk but look as if they're going to fall backwards. They're walking like that, it looks, they call it as retro propulsion. Retro means backwards. Propulsion means movement. Backward, as if they're going to fall backwards. So frontal ataxia. So that one will have problem with memories, cognition function along with motor issues. Walking seems to be retro propulsion. So some signs that they can associate with frontal lobe damage. So what we can do is we can think of something what we call as perseveration. Perseveration. Type perseveration, put comma frontal lobe. Perseveration.
For the context.
Frontal lobe, yeah. What is perseveration? So the person loses control, inhibition. For example, you're asking him to clean this, he will keep on cleaning it. He cannot stop it unless we stop it. He keeps on speaking unless you make him to stop. So he has lost his inhibition of control. So that could be a sign of frontal lobe not functioning well. So frontal ataxia. So the next one, what you saw was truncal ataxia. So truncal ataxia, you could see when you make him to stand or sit, the trunk moves forward or backwards. Or we see antero-posterior movement of the head, titubation. Or if you want to check him more, you can ask him to take the heel around the shin of tibia. What happens? He does that. So that one you can look out for truncal ataxia. Then other kinds are there, but cerebellar ataxia, truncal ataxia, frontal ataxia, vestibular ataxia. But in today's class, we are interested with cerebellar ataxia, and we also will try to define other types and how they look like. So let's proceed further with the assessment. So the next assessment is going to be your, please come here, gentlemen. The one is going to be your, first one is non-equilibrium. Non-equilibrium. So in a non-equilibrium testing, we are trying to assess for the person's static, dynamic components. Then you are trying to check for gross and fine motor components. That's your non-equilibrium. Position, sitting or supine. For this class, let's take sitting as a reference point. So what I want to do is, I want to take both your arms outwards. Try and touch your index finger like this. First, you demonstrate to the patient and ask him to do that. Yeah, do that, please. Good. Then, what you try to do is abduct your shoulders. Try to touch your tip of your nose with your index finger. Yeah. Then what you try to do is, please keep your arms down. Keep your arms down. Try to take your finger. Hello. Yeah, fine. Your right hand, please. Try to touch my fingertip. Take your nose, please. Tracking of the fingers. So we ask him to track it. Okay. So what you're trying to do is place your hand on your thigh and just lift the fingers up. Let the wrist be on your thumb. Faster, la. So rapid alternating movements. Try to do pronation, supination. Draw a circle, please. With your hand, yeah. Draw a circle.
Follow instruction.
So then what you try to do is, keep your feet on the floor. Just tap your forefoot. Just tap your forefoot up and down. Okay, thank you. So draw your heel over the shin of tibia. Then what we can also do is alternating. Touch your knee. You can take this one. Alternate heel to knee to shin. Heel to knee. Alternating. Yeah, the other one. Yeah. Change. Heel to knee. Heel to knee. Heel to knee. Alternating. Okay, that we can do. So these are some of the things that we can do in sitting, and you can also ask them to do in supine posture. So this one is going to be your non-equilibrium, used for static dynamic components, used for gross and fine motor. So now you're going to do your, please get up gentlemen, equilibrium testing. So equilibrium testing is done in sitting or in standing. We're going to use both static and dynamic components for this one. Position, standing or sitting. So now let's stand. So what I want to do is stand with a normal base of support. Normal base of support. Where is able to maintain it. Close your eyes, please. Wrong. So stand with a closed base of support. Eyes open. Eyes closed. Then stand with 1 foot before the other. Eyes open and eyes closed. Arms crossed over. So this one is going to be your. What kind of Roberts test is this? Okay. What kind of Roberts test is this? Eyes closed and 1 foot before the other and arms crossed over. What's the name of this test? Romberg. Yeah, you know Romberg. Yeah.
Yeah, but I can't remember the name suddenly.
So we call it as a sharpened Romberg's test. Sharpened Romberg's test. It's a progression because it needs more amount of. So one thing what you have to remember is when you're trying to do Romberg's test, it's a test. It's not a test for cerebellum. Romberg's test is that. Can you please turn around? Romberg's test is a test for dorsal column. It's a dorsal column test. So there's a posterior side of the spinal cord. We call it as a dorsal column. We got a front side. We call it as a ventral column. So the ventral column deals with motor function. The back, the posterior, the dorsal column deals with sensation. Sensation like what? Superficial or deep? The dorsal column of the spinal cord deals with the deep sensation, proprioception, kinesthesia, pressure, vibration. So, Romberg's test is a test for proprioception, that is integrity of the dorsal column. Romberg's test is not a test for cerebellum. It's a test for dorsal column, for proprioception. So, if you want to make a simple test to know whether the problem is with the cerebellum or with the proprioception, you ask him to walk with eyes open and eyes closed. So if he's going to have problem in walking with eyes closed, what could be the problem now? Please walk, sir, with eyes closed. And walk with problem, yeah, don't get to yourself. So what could be the issue? He's having problem in walking with eyes closed. So the problem is with proprioception. You got that? If he's going to have problem in walking with eyes open, then it could be a problem of cerebellum.
So if with the eyes open, we don't have to test with the eyes closed, right? If
he already has a problem. So one more thing that you have to remember is sensory ataxia. Sensory ataxia. How is sensory ataxia presenting? How does it present? Sensory ataxia. Ataxia. So what's the problem there? How to identify a person with a sensory ataxia? So how is the presentation with the sensory ataxia?
The patient, I don't know.
How do you see, how on observation, how does a patient present with a sensory ataxia to the clinic or anywhere?
The person having difficult to interpret what kind of.
No, in a sensory ataxia, we got something what we call as a sensory ataxic gait. Sensory ataxic gait. When you look at them, he lifts the feet and slap to the floor as he walks. He slaps to the floor. Why? Because he doesn't have enough of sensory feedback. So he wants more amount of sensory feedback, so he slaps to the floor. So we call it as a stomping gait. Stomping gait. Stomping gait. We call it as a sensory ataxic gait. So usually this sensory ataxic gait will be seen in patients with tabes dorsalis. TABES-DORSALIS. When you go home, read it loud. What causes tabes dorsalis? So this is one which causes. What are the conditions that could cause sensory ataxia? So we have seen equilibrium. Now we have been going through equilibrium testing. So you march, you stand, tandem. So walk tandem. Walk in a straight line, please. Come back and walk in a straight line. Come back and walk in a straight line. Yeah. Not tandem, straight line. Yeah. Walk in a straight line. Walk with looking up, down, and sideways. Normally, like you walk like look up, down, sideways. Now, why you want walk like a robot? Okay. This is really something. So what we do is then we ask him to walk with horizontal, vertical. So, as he walks, different arm movements. Walk, 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 walk. Stop. Walk. Stop. Turn. So we are seeing whether the person has got control, inhibition. Because usually inhibition is lost, right? So marching backwards, or walking backwards, walking forwards, walking sideways, then cross walking, cross walking. So you can ask him to do everything. So this is for your equilibrium testing. So we have seen Danish, we have seen non-equilibrium, and we see equilibrium, and we also be trying to explain what are the different kinds of ataxia with clinical significance, and we also explained about cerebellum. It's important connections. And one important thing, does the cerebellum has got gray and white matter? Does the cerebellum has got gray and white matter? So the cerebellum has gray and white matter. Gray and white matter. Okay. The white matter never leaves the cerebellum. The white matter doesn't leave the cerebellum. It connects the parts within the cerebellum. That's the thing that you have to remember. Gray and white matter of the cerebellum. And we have to remember, the cerebellum is connected to the brainstem. The cerebellum is connected to the brainstem through peduncle. Peduncle. We call it as cerebellar peduncles. Anterior, posterior, inferior peduncle. 3 peduncles connecting cerebellum to the brainstem. 3 peduncles. Okay. Thank you, ma'am. Thank you very much. So 3 peduncles. So this is important outline of your cerebellum. Just remember this. The gray matter is someone with neuronal cell bodies. Gray matter is neuronal cell bodies. Please remember, usually white matter forms tract because white matter contains highly richly myelinated axons. So they always carry signals. That's why tracts, spinal tracts are made up of white matter. Gray matter usually it contains neuronal cell bodies which connects with it as such. So this is something. So now let's try to look into how to manage. Can you get anyone get a pillow? 3 pillows, please. Let's try to look into the management. Okay. Yes, please. So when you're trying to improve cerebellar issues, usually what we're trying to look out is first we have to try to what are the two most common positions that we use in a day? Most common positions that we use in a day. Most common. So you're going to sit like this all this day. You're going to lie all the day. So why not? What's the most common position that we hold throughout the day? Yeah. Functional position.
Even
Either standing or sitting, right? Most of the time, either we sit or stand. So we have to develop stability. Before we go into coordination, we have to improve coordination. But it will be very useful for us to develop stability. Yet neck trunk control so that it could help with better coordination, better outcome. Because when I have a better stability, I can do a better movement. Without stability, I do a movement, I might fall. You got it? So let's try to develop this gentleman's head, neck, trunk control. So what we can do? So we can put him on a prone. Like on some prone. Now sleep now. Come a little bit. Yeah.
look so comfortable.
Look. A little bit after just wants to sleep. So what we try to do is, the thing is, we want them to have extension. We want to have an extension. So putting on this one creates extension. Okay. So if this gentleman is unable to extend it, we can try to give him quick tap. How to? No, don't do that. You're going to be losing the job next day. So what we do is brisk stroking. If it's a baby, we use rattle calls. If it's not a baby. No, we don't do that because it's not a baby. Okay, it's an adult. So we do stroking, or we can do vibration over the muscle bulk. Vibration.
Shaking?
No, vibration.
Oh.
Vibration over the muscle bulk, we can give. The thing is, when it holds the neck in position, so what happens to the muscle here? Is it contracting or co-contracting?
Contract.
Huh? Contracting or co-contracting? Co-contraction. That's the basic physiology. So when there is co-contraction, what happens? What kind of contraction is this? I know neck is contracting. What type of contraction is that? Co-contraction.
Not I don't know the word.
It's mandiri.
Apa tu?
Is like wait, I forget the word. Sumpah lupa sekejap.
Isometric contraction. This isometric means both agonist and antagonist are firing together. When the more the muscle groups are contracting as such, okay, it gives a better stability, better sense of hold. That's why we try to put into this. Okay, so co-contraction happens. So we are trying to put them in an extension position. Okay. Yes, gentlemen, enough of sleep. So, next, we can put them in sitting. Please sit now. Please sit. Sit. So, in sitting, how to improve neck control? In sitting, how to improve neck control? 5 marks I give you. Name.
Stroking.
Baby.
Pressure. Yeah. Ada pressure.
Oh tu yang key point tu?
Key point two. Center key point. No. This is one for. Yeah. So this. So key point of control.
Neck.
Something touchy, right? It's very touchy.
I don't want to touch.
Instruction.
I did.
Apa?
Tak ada juga.
Apa?
And
Apa? How to develop neck control and sitting We can use rhythmic stabilization. So other than rhythmic stabilization, an easy way to develop this contraction in the neck. We are making to hold it and we're trying to put pressure. What is that? What's the name la? This pressure. Jacobs and relaxation. What do you do? So we are trying to put pressure to the joint. So putting to this pressure into the joint causes contraction here too. So what we call it as?
That's why.
Yeah, that's what I want. That's what I want. The name.
I said pressure.
Yeah.
What's the name?
What's the name? Nama.
It's like the joint yang tu apa compression but
Joint compression. It's joint compression, nothing else. What's the name that you can
yeah actually satu.
Joint approximation.
Joint approximation. Very good. 5 marks. If you believe that. So, I think she's very gullible. You can easily say something and she believes it. I don't think so. Don't believe it. Okay? I told you already in the class, don't take things literally. Just for example, he understands, right? From diploma. So, joint approximation. Joint approximation is nothing but weight loading through the joint. Weight loading is going to trigger your GTP, Golgi tendon organ, the muscle spindle, wattles and whatnot, your mechanoreceptors. So this weight bearing, when you look at that, you can see, you find out what pressure building up. So it gives a better sense of neck step. Okay?
I
So-
will try.
Try please. Anything goes wrong, don't say that. So the next one is going to be off sitting. Next one, off sitting. Go off sitting. Off sitting, not W sitting. Not W sitting. W sitting is this. W sitting, we don't allow this. W sitting is bad for what? Apa? So W sitting we don't allow in neurological patients. Why? W sitting we don't allow in neurological patients. Why? What do you call? Spine problem. Hey, too much drama.
Hip dislocate.
My hip is dislocated now. This is too much drama. Very good, ma. W sitting will increase tone, increase spasticity. Don't allow W sitting in people with neurological disorders. Like CP child or any other person neurological problems. Don't put them in because it will increase spasticity. And also don't allow them to go into windsurf position. Come here, Evan. Come on, fast. One time. Lie down. This one is like a neurological patient. Go to supine.
He got into.
He got too much. He became a neurological patient. Become a neurological student, not a patient. Bob. Bagus. So we should not allow windsurf position. Windsurf position is a person with spasticity. So what is windsurf? It's like the wind. Relax, I'm not going to do anything. Don't jump. Relax. Don't be jumpy. So windsurf is moved on to one side, the arms are to one side, and it's like this. This is windsurf position. This is a windsurf position. We don't allow this. A windsurf position again causes tone increase. We don't want it. And one more thing what you have to remember is, in a neurological patient, sometimes putting in supine can cause increased tone. Why? 10 marks if you say that.
Because the master then.
Yeah. Nama. Fast.
I have problem with it.
Why we don't put them in supine in a neurological patient? Why? In a stroke patient, we don't put them in a supine for a long time. Why? We don't allow them neck movement like this to be like this. And why?
Is it starting at? No.
The first word starts with T.
Apa?
Upper. Nama.
Hidup.
So, jokes apart, whenever you're dealing with someone with a neurologically deficient person, putting in supine can cause SLTR, symmetrical, tonic, labyrinthine reflex. When you put him in supine, extension tone dominates. Bone to prone, bone to prone. So, when you go into put him in prone, flexor tone dominates.
But is it hard for all
No,
Yeah, for the
you can
stroke.
see this typically in stroke patients, and TBA patients.
Yeah.
Okay, so to break this, what you do? Usually, what position we put them in?
What posture?
What position? Go to supine gentlemen, please.
you put bantam?
So, usually, if you want to break that, we usually put them in side line. Side line is a position that can help you to break this ST line, and also it can break your ATNR and ST.
So are you on the good side or affected side?
Usually, we put them on this. Usually, we don't put the bad side going down in a stroke patient because shoulder and syndrome is already there. And another problem is shoulder pain, another problem, dislocation. So, if you want
The wife.
kill the patient, put them. So, usually we don't put them on the affected side because already there's a problem with musculoskeletal and also sensory and also circulation. So, we don't usually put them on an affected side. So, remember that if you want to, if you're seeing some extensor tone dominating, simple what you can do is flex, lift your legs. I'm trying to help you on the creating problem. So, you put a pillow and flex it. A little bit of flexion can break the extensor tone.
It also helps respiration.
Yeah. So it breaks your extensor tone. So simple things that we can make. Or you can put them in a prone on a wedge and flex it. If it's a flexor dominance.
On that?
So put on the
Yeah. But you have to be very careful that the face area is not going like this after something is dented.
And they can do like
Yes, absolutely. So then go to offsetting now. Offsetting. This is offsetting now. In which world now? So offsetting is this now. This is offsetting.
Oh, side. Side sitting.
oh your call add in 15 minutes.
Okay, this is side sitting. So side sitting can also be used for stability. Because this is a transitional position for a child from sitting to sideline or coming to sideline or going to sitting. Transition. So trying to hold. Half sitting can also be used. So the next thing what he has to do is he has to improve his balance in sitting. Sit gentlemen. So you can do half sitting and first whenever you're trying balance or anything in a person with a problem with balance, please remember the basic criteria. First thing, any activity should be given in a low gravity position. Low gravity and a stable support. You don't make him do. Can you get the ball, please? So we don't make him to give a ball and make him to sit on the ball. He will not come the next day. He's going to fall because it's very difficult for him to maintain his balance. So initially, any balance activity should be given on a low gravity on a stable surface. Basically, supine or sitting. Don't sleep. Okay, so either sitting or supine position. That we are very clear about. So what we can do out of. So to make this sitting happen, what are the things that you have to do before going into the, excuse me. Go to mat activities now. These are the things that you have to do, guys. Please remember. That we already done. Prone on elbow. Prone on elbow. Prone on elbow.
Roll.
Yeah, prone on elbow. Good posture. Hit neck, shoulder, stability. Babush. And go on hands loud. One hand, please. Hand. Go on hand. Oh, hand also no. Okay. Again now, Buddha. You see the neck? Feel the neck now. Feel the neck. She's angry with you. Yeah. You're all doing very well.
Yeah.
So what we're trying to do is, sorry gentlemen, we can feel the contraction of the neck musculature, shoulder musculature, and the scapula musculature. So good one. Then what we try to do, all, this is the you have done your mat activities, right?
Yeah.
So one. And we ask you to slowly bring the hands back. So this will be the control point for the lower limb to move. The key thing that you have to remember is, I think he's not right. Hey, not like a camel man. So the thing that we do is, the shoulder should be straight to the joint. And the hip should be straight to the knees. Is it straight? I don't think so. A little bit.
But when she doesn't have elbow control, we cannot do like this.
Yeah.
No, that's why the first one, the prone
Prone and hands. Okay. Now, this one. The next one is going to be your
abdomen.
abdomen.
Oh, no, I mean the straighten.
2-point kneeling. 2-point kneeling. Then he has to go for
Half knee.
half knee. Then he has to go for standing. Don't pull me down. I'm a old man. I got a family. Oh, anything happens, inform my wife. So, tell him this fellow pull me down. So, what do you want to do now? He's trying to look at the iPad, the ceiling. My goodness. You think suddenly you've grown up now? So, come here. He's touching whether the ceiling is touching his head. Okay, so then get the physio ball. So, sit here, gentlemen. And please remember, if you want to develop equilibrium and correction reaction, please go. I think important thing for them who is working in a hospital. To clinic. Yeah. Come. No, that's fine. Go to 4 point. So this quarter point position. Quarter point position is a good position for equilibrium reaction and correction reactions and reaching out. You can use this for those purposes. Yeah, please come, sir. Still here with you. Sitting. So now, as you already know, sitting on a physio ball needs firing of your core muscle and your lower limb muscles. Firing of your core muscle will give a better trunk obviously. So you're also firing up your lower limb strength. And what you're trying to do is, first initially you're going to ask him to hold it. Then as it progresses, this one, after he has mastered on a stable surface, then you progress it. Reach out, then reaching out, then reaching out. You can keep an object, ask him to pick it up. And go on. Later. Then, so look at the side, please. Activities. Okay. You can do activities in sitting. Okay. Then, are you okay? Now you're confident in sitting? You're ready to go. So, don't go to another therapist. So the next one, go to the bed. Don't bother me next. You go to that therapist. Go to that clinic. Okay. So please come. So the next thing that you have to remember is, in a person with a cerebral disorder, they have a tendency to do long growth. They have a tendency to do long growth. Do you want to promote it? No. We want to promote segmental. For example, he wants to go to the side. So the gentleman will be going, as a whole. but we don't want that. So what we want to do practice them. So come to the side, sir, please. Come here. So usually we don't want him to do a log rolling, right? So what we can ask him to do, sir, can you please bend your, can you do that? So I'll try to put a little bit of
Pressure.
pressure. Pressure, as you said, to give him a better sense of control, stability, and feeling of the movement. So turn to the side slowly and try to move it. We are also trying to give it tactile and trying to, if you are too close to it, then trying to press. Yeah, push down. Pull your feet down. Push. So ask him to come. So there's a tendency to do log rolling. We don't want it to promote it. We want to promote only segmental. We want to do only segmental rolling. That we have to keep in mind. So the next thing is he has to walk. Sir, for walking, what we can do for you, sir? Please come. What are the things that we can do for walking, please? Bridging. Do bridging. Unilateral bridging, please. This one can also be used for front stability. It's either way around. It's not hard and fast rules. Okay? Go into prone, please. In prone, go to quarter quad, please. Crawling, please. Crawling. This one has got a problem with understanding. This patient has got frontal ataxia. Both motor and cognitive issues are persistent. Okay, so I will crawl. There's a therapist crawl. So what to do with this? So we have to crawl. My goodness. I think I have 2 breakfasts, 2 lunch. So crawling. So crawling was a good one because crawling promotes reciprocal, like walking. Right? So it promotes reciprocal walking. So crawling is a good one for making him to stand. Then what you try to do was walking. So for walking, in a person with ataxic gait, the problem is with a wide-based gait, right? So what we can do? We can make the marking. So sometimes what we try to do is we make a marking on both the sides and ask them to walk like this. Again, we are promoting wide-based gait. We don't want it. So please remember, whenever you are promoting someone to walk, right? What they're going to do is they're going to, please come here, gentlemen. So come here. They're going to make a marking, alternate foot marks. Don't press on my yeah.
So I think you need to see over there.
Okay.
Yeah. Because they cannot see.
Keep here. This one, marking. Marking.
Can we use a cue?
We can cue or we can also make marks. So make sure the marking reflects this person's age, gender, step and stride. Don't mark like this and make him to walk like that. It should represent a normal step and stride with a little bit of narrowness. Yeah. So if you want to get a towel, please. Towel la. Or towel la. Wow. So we can also come. Visualize this entire.
Okay.
So lift your and place it here against resistance. This gives a better sense of movement and also control. Use a taraband, don't use a tabla. They will ask you who taught you. A taraband. So initially you're not going to use a taraband of which color? Which one? Yeah, that one will be high resistance. So use a low resistance taraband. And also he's missing. So before you initiate, ask him to practice. No, ask him to hold and ask him to go forward, backward movement. Let him get the sense of heel movement. Heel off, toe off, heel off. So forward, backward movement. And the gentleman is not having knee flexion. So you can also ask him to bend it against a resistance. Okay. Try to practice whichever movement he finds it difficult, then make him to walk. In walking also, initially try to give resistance. It can give a better sense of movement. Okay. So finally, what we're going to do is we're going to give him frontal exercises. So frontal exercises or specialized exercises to promote coordination. So please lie down, gentlemen. Let's. So important things to remember before you proceed with coordination exercises. First thing, whenever you're trying to give coordination exercises, the therapy session should be only for 30 minutes, not more than that. If you're going to keep it for a long time, fatigue comes in, tiredness. So incoordination increases. We don't want that. So, and even the 30 minutes should be broken down into 10 minutes. 10 minute session.
Or break.
Break it. Next thing, no emotional disturbances or anxiety. It will increase incoordination. The room should not be like this, too cold or too warm. It can also impact coordination. No loud noises. No loud noises or bright lights. Let it be a neutral environment. No external disturbances. Okay? The fifth point you have to remember is total concentration. Total concentration of the patient. The next sixth point, active participation of the individual. Very important point when you're trying to do, he or she should be able to see the movement. He or she should be able to see the movement. So whenever, for example, he's trying to do the movement for the lower limb. For example, let me demonstrate the lower limb movement. So you should push it in such a way like that. We should go. Like that.
Excuse me, sir. The call is ending in 1 minute.
1 minute.
Tell them you will be sending it.
Sorry?
Sir, we'll send it back. We'll send it back. Close it and send it again, please. The patient in such a way he or she is able to see the movement. It's very important. So 3 things you have to remember in frontal exercises. One is concentration. Second one, precision. The movement should be precise. Third one, repetition. You don't ask them to do for one time and stop it. You have to repeat the movement. The fourth important thing that you have to remember is there should be a tactile guidance. There should be an auditory. Sir, can you place it at 1? Can you place it at 2 and 3? Then there should be a visual feedback. You need to see tactile, auditory, and visual feedback. So what we try to do was initially we make a marking 1, 2, 3, 4, whatever it is. We make, and what we try to do is we ask him to initially he has to do in a low gravity position. But first we are going to demonstrate the movement what he has to do. You can use a metronome, beat, tuck, 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 beat, or you can according to number. Make a sound. So as you make the sound, slowly drag your feet, look at the movement, and take it to each number according to the beat. This was easy. To make it faster, we increase the speed of the movement. Good. So later, we have to progress it. For progression, what you do is try to ask him to lift the feet, the limb away from support. Now ask him to move from 1, 2, 3, and 4. It's difficult for him. So this needs more amount of neuromuscular.
Hello, sir. Cannot hear you.
You cannot hear me.
Now?
We cannot hear you anything, sir.
I cannot hear.
Hello?
I think you muted someone. Maybe you should unmute them.
No, I mute.
Can you hear me now?
I can hear you. Okay.
Yes, sir.
Hear me. Okay. So what happens here is, so later you're going to ask him to lift, then ask him to move the limb. It's difficult. It's progression. If you want to show progression, increase the speed, increase the complexity and reduce the
Repetition.
support.
Support.
Reduce the support. Ask him to lift. So what are the things that we can do here? We can do for adduction, from abduction, we can do adduction, then we can do abduction in lower. We can also do, we can also try to do knee flexion, knee extension. You can also do hip flexion and extension inside. Inside. Okay, it depends upon you. So sit. If you want to do sitting, you can also ask him to do sit. So initially, we're going to ask him to slide. Slide your feet. 1, 2, 3, 4. Okay. So as a slide your heel on the numbers that have been marked. Okay. 1, 2, 3, 4. Extension, flexion. Again, sir, bring it close. 1, 4, 3, 2, 1. Again, you can do an abduction. 1, 2, 3, and again abduction. So you can also do the upper limb if you want to do. You can also do water. 1, 2, 3, 4. Or you can keep it table and try to move it from abduction to adduction. 2, 3, 4. 1, 2, abduction. And you can also do keep an elbow flexed. 1, 2, internal and external rotation. Inwards and outwards. Okay. So we just use the imagination. So the things that I have to remember is, I told you 10 things. 1, the session should not be more than 30 minutes. It should be broken into 10. And the most important thing that I have to remember is, before you start your exercises for coordination, you have to make the person to relax. So you can give breathing exercises, or you can give Jacobson relaxation techniques. Jacobson relaxation technique. So how to do Jacobson relaxation techniques? So lie down. So Jacobson relaxation technique is not rocket science. Very simple. Where we use alternating hold and relax. Alternating hold and relax. And we use mental imagery. Mental imagery. So just relax yourself. Okay. Take a deep breath. Take a breath in slowly. And try to slowly exhale. Just concentrate on your breathing. No need to try to too hard. Okay. Try to take a deep breath as much as possible. As easily you could be. Don't strain yourself. And try to slowly let go. Inhale and exhale gently. Take a breath out and leave it out slowly. So after this, what happens here is, we're going to ask him to think of something pleasant, mental imagery. Close your eyes now and think of something. Don't think about your classes, exams, marks. Okay, don't think about anything. Results, please don't think about it. You're going to get spasticity. So, yeah. So don't do anything. So all you have to think about right now is think of your
Girlfriend.
No, that's very stressful.
Oh,
Money.
no.
Money
Why
is
you
stressful.
want to marry sir?
Marriage. No, I do that. So what we can ask him to do? Maybe you think of something on a beach where the skies are blue, the blue waters are there, you're traveling, sir, you're on a beach. Okay? The waves are all rising and falling down slowly. Okay? The breeze is so good. The sun is so pleasant. All around blue waters. Think of that. Just relax yourself. So, as you're thinking, can you hold on your shoulder? Can you tighten your shoulder muscles? Don't strain yourself. Just hold it. Try to strengthen. Okay? Hold it. Hold it for 5 seconds. And relax for 10 seconds. Hold should be less. Relax should be more. So you can do individually, or you can ask him to tighten the entire body. So, flex. Just try to increase your tone all through the body. Yeah. Hold it for 5 seconds and relax it for 10 seconds. That's it. That's alternative hold and relax. Actually, hold and relax will calm the muscles. Okay. After this, you can progress to your. After you're relaxing, you can take him for frontal exercises. Okay. So take 5 minutes break. I know it's too much and the head will be spinning. So guys, just take a break for 5 minutes and come back. Let's topic now. Topic 2. So that one is a good one. You can find everything there. Rehab measures.
Thank you.
You can find all outcome measures there. Bro, hey, come on, hey. Okay. Let's just no one wants to go into Chrome. You're a capital brain patient.
How patience?
I'm good. Always on the. You're a TBA patient. Go there. In the middle. You're a TBA. I don't want to be called on. Already your head is broken. So, guys, for unconscious patient, you're feeling uncomfortable. Wait. So, now we are taking TBI as a referral point for unconscious patient. So before we go into unconscious patient or coma, we have to understand what is consciousness. Consciousness is made up of three things. One, the patient should be wakefulness. Second, the patient should be having awareness. I should be aware of myself and my surroundings. The third one, alert. I should be able to respond to my external or internal stimuli. I should be there. Three things should be there. So now, what is coma? Please close your eyes. Coma is a profound state of unconsciousness. Total absence of cerebral function, no eye opening, no responses. That's your coma. Complete absence of cerebral function. A person can be in coma for a month, or unfortunately they might die, or they go into another state, what we call as persistent vegetative state. Persistent vegetative state. Where you find, what do you find there? Where we find brainstem reflexes are intact. Brainstem and thalamic reflexes are intact. Sleep-awake cycle could be there. Temperature regulation could be there. So those reflexes are present. But the person doesn't have any kind of awareness. Everything happens on a reflex level. Lip smacking, grimacing, anything can happen. But everything happens on a reflex level. He does not understand. So the next state, what they call it as minimally conscious state. To call something as a minimally conscious state, there should be 4 things. One is yes or no responses. Then verbalization, intelligent verbalization should be there. Then 3 and 4, final count. Okay, 4 things have to be there to say someone is in a minimally conscious state. A minimally conscious state is something where there is a definitive awareness to self and environment.
Awareness to?
Self and awareness to the environment.
Self-awareness.
Any stimuli, he might open the eyes and see. So there is some kind of minimal awareness, consciousness to the. That's why we call it as a minimally conscious state. But persistent vegetative state is not a state of awareness. It's a state where the person responds only through reflex levels. That too, primitive reflexes, brainstem reflexes are there, and thalamic reflexes are. So that's the coma. That's what. So what can cause coma? Coma could be caused because of trauma, or it could be caused because of some metabolic disorders like diabetes. Uncontrolled sugar can lead to ketoacidosis. Ketoacidosis can cause coma. Any growth or tumor, it can cause coma. Any bleeding, rupture can cause coma. So when you talk about coma, we should also remember concussion and contusion. Concussion is a brief loss of consciousness, or there's a brief period of confusion, then it comes off. But contusion is something where we see bruising of the small blood vessels. Blood capillaries are being bruised because of an injury. Okay. So when you talk about TBI, we have to remember it can be an open or a closed type. If the skull or anything is being open or the internal structures are being exposed, we call it as an open type. Closed type, a trauma to the head and something goes wrong inside the brain. Closed and open type. Or we call it as coop contra coop. Coop, C-O-U-P. The person falls down, hits the frontal area, and the problem is in the frontal area. We call it as coop, C-O-U-P. Or if the person is falling anything, and the brain substance moves and hits at the occipital area, where it causes problem to the occipital area, then we call it as contra coop. The problem is at one area, but the impact is in one area, but the problem has been seen on the other side. Coop, contra coop. Coop means we understand it's at the same side. Contra coop, impact is on one side, the problem appears to be on the other side. Coop, contra. So whenever have you seen a TBI patient in your work? Yes. So what do you observe in a TBI patient? In a TBI patient, the important things that should be looked out for is on observation. We're going to look out for any kind of external trauma. First thing, what I will be using is look out for raccoon eyes. R-A-C-O-O-N. You know what's a raccoon, right?
Yeah.
What happens to the raccoon around the eyes? Dark circle-like things. So we call this periorbital hematoma. There's periorbital hematoma, red color bruising all around the eyes. That's periorbital hematoma. Or we try to see whether any liquid is oozing through the ears. What can ooze through the ears? What can ooze through the eyes? Sorry, through the ears. Two things can come. One is cerebrospinal fluid. CSF can ooze. That's why whenever you're making an assessment, you can make an initial assessment before the physician comes. Oozing is happening. Maybe it could be a CSF. We call this autoria. Or blood can come through the ears. Blood. We call it as hemotympanum. Hemo is blood. Tympanum is ear. So hemotympanum. Either blood can ooze or cerebrospinal fluid can ooze. What do we call it as? We call it as an autoria. Or it can come through the nose. We call it as rhinorrhea. If the CSF comes through the nose, we call it as rhinorrhea. Then we can also look out for battle sign. Battle sign is bruising over the mastoid process. Bruising. There will be bruising over the mastoid process. And we can also look for any associated fractures. Then the important thing that we can look out for is we can look for any abnormal posturing. Abnormal posturing. What are the abnormal posturing that you can look out for?
Fracture.
Abnormal pathological posturing, neurological posturing lab, which indicates brain damage. Yes, okay.
Hip reduction with slight reflex.
So two things we can observe. One we call it as decorticate and decerebrate. Decorticate, decerebrate posture. Please read. If I'm going to explain, it's difficult for you because it's a new word. Type and see that. Decerebrate. D-E-C-E-R-E-B-E-R-A-T-E. Decerebrate. Decerebrate and decorticate posturing. So decerebrate is extension or flexion? Hello. Decerebrate is flexion or extension?
Extension.
Decerebrate.
Extension. Extension.
Decerebrate is extension posturing. Decorticate is flexion. So decerebrate is going to be extension posturing. So what happens is, please remember, both in decorticate and decerebrate, the lower limb will be extended across like this. Okay? The changes you have to see is only in the upper limb. So you say decerebrate is going to be extension. So what happens? Adducted, internally rotated, it's like this. and the wrist is flexed. So this is your decerebrate portion. So it indicates brain damage. Not a good sign. Not a. So which area of the brain is affected? Next question for you. If you're going to see this extensor portioning, there is a decerebrate. Which area of the brain is affected? Midbrain. Which one? See.
No, I just see the
No, don't see only that. See which area. Then only useful you, right? Which area? Come on.
area. Brainstem. Lower midbrain.
Lower midbrain.
Lower midbrain.
So your midbrain area is affected. So the person gets a decerebrate portion. So the next one is going to be your decorticate. Again, decorticate, extension, crossed over, and the hands are towards the midline and is like this. So again, this one shows severe brain damage. This one indicates severe brain damage. So which area is affected here, please?
Midbrain.
It's a midbrain damage. So decorticate, decerebrate. Not at all good. You have to observe for abnormal portion. Sometimes you can also find hemiplegic portion in tibia. So it's not an hard and fast rule. Sometimes stone can be on one side or bilaterally. But the important thing that we have to know is abnormal. Okay. The important thing that you have to know is posturing. Abnormal posturing. Why? Because it indicates severe brain damage and we try to look out for observation. The next thing we're going to look out for abnormal breathing patterns. So what are the abnormal breathing patterns? Fast.
Yeah.
I'll stop with abnormal breathing patterns. Next class we'll do.
Okay.
Abnormal breathing patterns. What? Fast.
Ethical breathing too.
Happy breathing. Who dies now?
You like the
Abnormal breathing patterns. What I mean is what I mean.
Yeah.
What's your name, please?
easier.
Isyan.
Atika.
Atika. Isyan. No. So what's your name now?
Zol, your name.
Zul. Zul. No. So, Isyan. Atika. Yeah. So can you please tell me abnormal breathing patterns that we should be aware of as a physio? Fast lab.
Repeat it.
So guys, please remember certain breathing patterns we should be aware of. First one is going to be your paroxysmal nocturnal dyspnea. Paroxysmal nocturnal dyspnea. Don't look like that. It's very scary. Atika. So paroxysmal nocturnal dyspnea. Paroxysmal means PAROXYSMAL. Paroxysmal means continuous, which happens often. So what happens? This gentleman will wake up many times in the night because he cannot breathe. Suddenly wake up now. Cannot breathe. Suddenly wake up. That's it. Suddenly in the night he wakes up because he cannot breathe. Please lie down. Because this could be a sign of heart failure. Maybe, don't say Sam said like that.
Oh, maybe.
It could be a sign of heart failure. If any one of us or any of our relatives or anyone are saying like that, we can advise them, please see a cardiologist immediately. Not a good sign. So the next breathing pattern that we should be aware of, orthopnea. Orthopnea. So the gentleman will find it difficult to breathe in a supine position. He'll be feeling better when he comes to an upright position. In an upright position, he feels better to breathe. Again, it could be a sign of heart failure. Again, it could be a sign of heart failure. The next one that you have to remember is Kussmaul breathing. Kussmaul breathing. So Kussmaul breathing is something where you will find in a person, unfortunately, who has got uncontrolled diabetes. Because if there is uncontrolled diabetes, there is going to be a lot of ketoacidosis will be there. So there will be too much of carbon dioxide inside. So what it means, So they call it as pant for breathing, under for breathing. He wants to push excessive CO2 outside, not out of the good one. It will cause comatose death. So Usman breathing. So the next breathing pattern you should be aware of is going to be Chain-Stokes breathing. Cheyne. What is Chain-Stokes breathing? It's an important one that you have to know. So that one is ascendo, crescendo, then a stop. Then it seems as if I stop breathing. Ascendo, crescendo, pass. Ascendo, crescendo. Ascendo means going up, down, and a pass. So what causes it? Again, sealer. Again, it has to do with your heart lah.
Yeah, it's breathing. Yeah, it's hard.
So, guys, thank you very much. I hope it was useful for you. See you in the next class. Thank you.